before we start, what is Boerhaave syndrome?
Rupture of the esophagus lower.
Yeah, it is due to which trauma?
Vomiting against closed glottis.
Yeah, no, which trauma? Barotrauma. It is due to barotrauma. Yeah. Okay. What is the location, most common location of Boerhaave syndrome?
Posterior, lateral, left posterior, lower.
Left lower posterior. Okay. Same way, what is the location of Mallory-Weiss tear? Mallory-Weiss tear.
Curvature.
Lesser curvature.
Lesser curvature near the esophageal gastric junction. And do you require to do a surgery in Mallory-Weiss tear?
No.
No need.
Yeah. Okay. Okay. So now we will start with stomach. In stomach, most you know what is this? This is the peptic ulcer disease. Peptic ulcer disease. So the most common type is duodenal ulcer. Ulcers can occur anywhere. It can occur in the gastric region. Oh, this is vanishing. Ulcers can occur anywhere. It can occur in the stomach. Then it is known as gastric ulcer. Then after stomach, what are the parts of small intestine? What are the three parts of small intestine?
Duodenum, jejunum, ileum.
Duodenum, jejunum, ileum. Yeah. In the duodenum is again divided into D1, D2, D3, and D4. D1, D2, D3, and D4. 4 regions it is divided into. Okay. In the 4 regions also ulcers can occur. Here also ulcers can occur. Here also ulcers can occur. What is an ulcer? Define an ulcer.
Erosion of.
No, the classic definition of an ulcer is a breach in the continuity of epithelium. Okay, any epithelium, either inside, outside, anywhere, a breach in the continuity, a break in the continuity of the epithelium is known as ulcer. So, duodenal ulcers, gastric ulcers occur here, duodenal ulcers occur here. So, what is the difference basically is, out of these, most common are the duodenal ulcers, most common. But what is the basic difference is, duodenal ulcers, why is ulcer actually, it is known as peptic ulcer disease. Why is it known as peptic ulcer disease? Just
The
guess.
role played by pepsin.
Okay.
Gastric acid secretion.
Yeah. See that acid secretion, we think acid secretion will lead to ulcer, right? Increased acid will cause ulcer, but that is true only for duodenal ulcer. Hypersecretion will cause duodenal ulcer, not gastric ulcer. Gastric ulcer is due to loss of defenses. Here also same, like in stones, like inhibitors are there, promoters are there in stones, right? In the same way here also there are some substances which will acid and all these substances will increase the chance of, will increase the acidity and will increase the chance of ulcer formation. And bicarbonate, some mucus secretions, mucus secreting goblet cells, these cells will help to decrease the chance of mucosal injury. Okay, if the defenses are lost, if these defenses are lost, then gastric ulcers will be present. Okay, so that is the major difference. Understand the basic difference between both of them. Duodenal ulcer is due to acid hypersecretion. Okay, and gastric ulcers are due to not acid hypersecretion. They are due to loss of defensive mechanisms that prevent ulcer formation. Is it clear?
Yes, sir.
Yeah, and then gastric ulcer, if you take some food, immediately the patient will have pain in gastric ulcer. Okay, whereas in duodenal ulcer, if you take some food, because it's hypersecretion, the same point we can explain everything. Because the patient takes food, this hypersecreted acid will get nullified with the food. So the patient will have decreased pain in duodenal ulcer. So which patient will be, how the patient will, if the patient comes to you, on seeing him, how you can tell whether it is a gastric ulcer or duodenal ulcer? On seeing their weight and general examination, how can you tell? Gastric ulcer patient will be obese or malnourished? Malnourished. Yeah, because once he takes pain, once he takes food, he will have severe pain. So he will avoid food. Okay, they will be afraid of food. Food phobia they will have. And whereas duodenal ulcer patients, how they will present? Yeah, they will present obese because whenever they eat food, they will have this hypersecretion will be nullified with the food. So they will keep on keep on ingesting much food and they will become obese when they present to you. Okay. So food aggravates pain and food relieves pain. In the same way, vomiting is common. Okay. They feel gastric because whenever they eat, they'll have pain. They'll feel like vomiting. Okay. And duodenum, that vomiting is not common. And gastric ulcers, they present more likely as hematemesis. With hematemesis, what is this hematemesis? Is blood in
Vomit.
Vomit.
vomiting. But in the same way, if duodenal ulcer bleeds, it will not come outside. Okay, most of because of the pylorus here and the gastroesophageal junction here, it will manifest as
Melina.
melena. Okay, is melena upper GI bleed or lower GI bleed?
Lower GI
Upper-
bleed.
No, melena is lower.
Upper.
Melena is upper GI bleed only. Okay.
Okay.
Hematochezia is lower GI.
Yeah, hematochezia is lower GI bleed.
Right,
Hematemesis.
okay.
Yeah. Hematemesis, melena, hematochezia. These two are upper GI bleeds only. Okay, but this why that what is melena? Black tarry colored stools. Why? It travels all the way from duodenum or jejunum. It travels all the way in the intestine. It travels the colon, and by the time it reaches the hematine degrades and it becomes black in color. But this is an example of upper GI. This is a pointer for upper GI bleed only. Both of them. Fresh colored bleeding hematochezia is from lower GI. Okay. So we'll a few points about duodenal ulcer. The most common site is D1, D1, D2, D3, D4. I told you, right? In D1, the most common ulcers are present. Most common site D1. And see, duodenum is a tube again. A tube. The anterior ulcers are posterior type. Ulcers can form on the anterior surface. Ulcers can come on the posterior wall. Okay. So if the anterior ulcers, they perforate. Posterior ulcers, they bleed. Okay. Because see, this is the duodenum posterior wall. If this is an ulcer, there will be a blood vessel running beneath. There will be a blood vessel running beneath like this. Okay. So whenever the ulcer bleeds, ulcer will also cause that artery to bleed. So these patients will present with hematemesis or melena. Okay. Anterior ulcers usually perforate. Posterior ulcers usually bleed. Unusual site of ulcer. Suppose see, most of the times it is in D1, D2. If they are seen in unusual locations, then you have to suspect some other syndromes like Zollinger-Ellison syndrome, which we'll talk tomorrow. Okay. In pancreas, we'll talk about it. Zollinger-Ellison syndrome. And indication for surgery, if the patient is bleeding a lot, then we have to do surgery. Otherwise, you can manage conservatively with proton pump inhibitors. Okay. Yes, no?
Yes, sir.
Yes, sir. Okay, sir.
Yeah.
So what
why
about
does
the
this
inclusion of H2 blockers?
indication of H2 blockers?
Yeah.
Yeah,
No need of
H2 blockers
usage.
were used once like 10-15 years back. H2 blockers were used rampantly, but because of the side effects and safety profile of proton pump inhibitors, everybody now we are using proton pump inhibitors. Still in the market, only Rantac is there. Cimetidine, Rantac, so many of them came, but because it causes gynecomastia and some of them cause renal failure, so only Rantac is used. Ranitidine, you might have heard about ranitidine, right? Ranitidine
Yes,
used.
sir.
Then nowadays we use proton pump inhibitors like anything. We have
20% rabiprazole.
yeah, we are using only PPIs. Nobody is using H2 blockers except some old timers. Okay. So why does this happen? Why anterior ulcers perforate and posterior ulcers bleed? Why that this happen? Two reasons are there for that. One is, see, this is the duodenum here. Anterior surface, there is no covering over it. Okay, anterior surface, it is open, no covering over it, and there is no vessel running over it. So an ulcer is there. If it gets deepens, it just perforates. An anterior ulcer will perforate. Whereas a posterior ulcer, posterior side, if an ulcer is there is a blood vessel running beneath. Okay, and this blood vessel will give away. It will open up, and the patient will present with hematemesis. So what is the most likely artery to bleed is gastroduodenal artery. GDA is nothing but it is the gastroduodenal artery. This is most likely to bleed in a case of posterior ulcer. Clear?
Yes, sir.
So now come to the gastric ulcer. Gastric ulcer. Before we go on to the gastric ulcer, what is the most common type of T? Tracheoesophageal fistula. Most common type of
Type C.
type C. Most common type of posturethral valve.
Type C.
Type?
Isn't it 1?
Yeah, it is type 1. It's not
Type
A, it's type 1. Okay. 1 minute. PUB is type 1. And eclasia?
That's 1 as well.
One.
Eclasia is 1. And gastric ulcer also, it is type 1. Okay. So you group it so that you will remember easily. Okay. Whenever there are some most commons, if they ask you, you just write it on a paper in the front of back of your book so that you will revise once you go before exam. One most common thing they will ask definitely. I am saying it for the past 6-7 years. One most common thing they will definitely ask. Okay. So see here. This is modified Johnson classification for gastric ulcer. Can anybody tell me what is the name of classification for tracheoesophageal fistula? I told you in the morning. If you
Ross.
remember, it is very good. Tracheoesophageal fistula, there is a classification, right?
Ross.
ABCDE. Very good. Okay. So, gastric ulcer, modified Johnson classification for gastric ulcer based on the location. Once, no need to remember these types and all, but just remember if it is, no need to mug it up for your exams. Just I understand that based on the position of the ulcer and based on the number of ulcer, they are given a classification like type 1, type 2, type 3, type 4, and type 5. So type 5 is the most common ulcer. And one patient comes to you, you give some proton pump inhibitors. His symptoms should subside. If he's having recurrence of pain, recurrent episodes of pain, then you have to always suspect. In gastric ulcer, you have to suspect malignancy. In duodenal ulcer, they rarely turn malignant. Gastric ulcers, they frequently turn malignant. So you have to keep them on follow up and you have to do a endoscopy. Okay? Yes, no?
So the previous slide, 1 second.
Yeah. The treatment's not necessary, that's why I'm skipping. These treatments
Okay.
type 1, type 2, type 3, type 4, the treatments are not necessary.
So towards the end of the session, will you be able to give the most frequently asked questions or something like that?
Actually, I don't have that questions with me, but like whenever exam is over, the students send me some questions, some doubts and all. So I recollect from them. If you want, I can give me some time. I'll just write it down and I'll give it to you.
Thank
Okay.
you, sir.
Yeah.
Thank you, sir.
Give me some time, at least 1 week, and I'll give it to Shiva or someone there. Okay.
Yeah, sure, sir.
Yeah, because once your exam is over, some people will start messaging me. So I'll pick up from them, and from the next class, I'll tell that this question is asked. This is why it is going on. Okay, we'll do like that. Okay, so that we can form a question bank after some time. Okay. So in gastric ulcer, that's okay, right? You have written this. Yes?
Yes, sir.
Yeah. In gastric ulcer, what are the indications for surgery? Okay. One is intractability, one is bleeding, and one is perforation. What is intractability? Intractable.
So the ulcer doesn't heal?
Yeah, the ulcer doesn't heal. So the patient will complain of recurrent abdominal pain. That is intractable ulcer. Then you have to go for a surgery. So you have to resect the ulcer. You have to do a wedge resection. Or if the ulcer is extensive, you have to do a partial gastrectomy and we have to reconstruct. That is for intractable ulcer. For bleeding ulcer, see, what is the vessel which will bleed in duodenal ulcer?
Gastroduodenal.
Gastroduodenal artery. Same way in gastric ulcer, it is a left gastric artery. Remember, left gastric artery usually bleeds in gastric ulcer. Left gastric artery. So we have to oversew the left gastric artery. Okay, and do a distal gastrectomy wherever the ulcer is there. Suppose left gastric artery, if the ulcer is there, we have to do a distal gastrectomy and we have to oversew the left gastric artery. In perforation, gastric perforation, we will put a omental patch. What is this omentum patch?
So take a part of omentum and you
Yeah.
wrap it on.
Yeah, very good. So omental patch is nothing but just is very simple. Just this is the stomach. If the ulcer is here, mostly in the lower part, ulcers will be there. If suppose the ulcer is there, most of the abdomen, there is a policeman of abdomen. That is the omentum will be lying here. So just we'll take a bit of momentum, we will close over it and we'll suture it. Okay, no need to approximate the tissue, just put the momentum, it will form a plug there. Okay, for perforation we can do that. Okay, now again come to duodenal ulcer complications, DU ulcer complications. Here also, what are the indications for surgery? See, if in failed endoscopy, you have done an endoscopy, the ulcer is bleeding, you have tried to cauterize it, even if it is not, it is not getting controlled. So, failed endoscopy 2 times, at least 2 times you should try, and then if it fails, then you get to go for surgery. Rare blood group. Why is it so? Rare blood group. Suppose the patient is having AB negative blood group. Rare blood groups. Why?
Due to profuse bleeding.
Yeah, if there is bleeding, we can't help, right? So, there is because of lack of availability of blood. If the patient is hemodynamically unstable, that is vitals are unstable, and if the patient is requiring more blood, like 6 units per day or 6 units of blood transfusion total or 3 units per day, then also this is also an indication for blood transfusion. And what surgery to be done in a bleeding ulcer? What surgery to be done? You should tell me what surgery to be done.
Vagotomy.
Sorry,
Bilruta.
say loudly.
We'll
Vagotomy.
do a duodenectomy and ligation.
Bilruta.
No need to remove the duodenum entirely. Open the duodenum. Do a duodenotomy. Open the duodenum. Identify the vessel which is bleeding. Close the vessel. Okay. In the same way, like gastric ulcer, you close the left gastric artery, right? In the same here, you close the which vessel in duodenal ulcer?
DGA.
GDA.
Oh, okay. Gastroduodenal. Fine.
Gastroduodenal artery. Yeah.
Sorry.
And look at this image carefully. What is this?
Perforation.
Yeah. How you did it? Very good. How did you identify it as a perforation?
Level of
Meniscus
gas
sign.
of fluid. Gas. Level of gas.
Okay.
Gas below diaphragm.
Gas below the diaphragm. That is what the answer I want. Gas under diaphragm. Gas under diaphragm. Here also there is something. What is this? Here also there is. This is the diaphragm. There is some gas on the diaphragm. What is this?
Fundus. Air.
Very good. This is the fundus. Morning I was telling in some. I was discussing about fundus gas shadow, and you were asking the image also. This is the image for that. There is
Yes,
fundus
sir.
gas shadow normally. Okay, below the
sir.
diaphragm. In the right side it's okay, but if you in the left side it's okay. But if you find gas in the below the diaphragm in the right side, this gas under the diaphragm, this is an indicator that there is some hollow viscous perforation. Hollow viscous perforation. It may be bowel, it may be fallopian tube, it may be gallbladder, but most of the times it is a bowel. Okay, duodenal perforation. Okay. So if you join general surgery, if you take your post radiation general surgery, in your first year post radiation, you'll be waiting for these cases. Okay, in your casualty, you'll be loving to see this one so that you can have a chance to operate. Okay, this is the case which will give to the first year students. Okay, so just remember this image. It will be classically, it will be like this. This is the diaphragm. There will be gas under the diaphragm. If there is gas under the diaphragm, it indicates that there is a bowel perforation and gas has leaked from there. Is it clear? Look at the image carefully. This may be asked as an image-based question also. Yes?
Pneumoperitoneum.
Yes?
Yes.
It was the pneumoperitoneum.
Yeah, it will cause pneumoperitoneum, but pneumoperitoneum is like when we fill in with our laparoscopy, that we call it as pneumoperitoneum. This is also pneumoperitoneum, gas in the peritoneum, but this is just gas under the diaphragm only here. Okay?
Okay.
So filling the peritoneum with gas is pneumoperitoneum. I thought it was just pathological, not during laparoscopy.
No, in laparoscopy also we will fill it with, no, it is both, like it is not only pathological. In laparoscopy, we create pneumoperitoneum artificially.
Okay.
We put a needle, we push gas inside CO2, so we create a pneumoperitoneum artificially. Okay?
Okay, sir. I didn't know even the artificial one will be referred to it as a pneumoperitoneum.
Yeah, it is also
That's-
pneumoperitoneum only.
Okay.
Okay, yeah. So how these patients will present? The patient will be classically, he will have Hippocratic faces, that is tense look, anxious, dry eyes, everything will be Hippocratic faces. Abdomen there will be guarding, and abdomen there will be rigidity. Both of them will be there. And the liver normally, when you palpate on the liver, there will be some dullness on the liver. If you percuss on the liver, there will be dullness on the liver. Okay, because liver is a solid structure. But what happened here? There is gas here. So this dullness of the liver will be obliterated. How will the node be then? If you percuss once there is a gas under diaphragm, how will the node be?
Damp.
Okay, any better term for that?
Dull.
No. Normally, if there is solid organ is there, it will be dull. If there is
Tympanic.
gas, it will be
Shifting dullness.
Resonant.
no. You understand the point? Understood? Say again, I'm telling. If you percuss on a solid organ, you will have a dull note. If you percuss on air, you will have a
Resonant.
resonant node. In abdomen, we call it as a tympanic node. In chest, if you palpate, it is a resonant node. We call it as a resonant node. In abdomen, this node has a different name. It is tympanic node. Tympanic node. Okay. Yes.
Yes, sir.
Yeah.
So the position for X-ray would be erect abdomen now, sir.
Yeah. That's what next. Yeah. Erect abdomen.
In a case.
X-ray abdomen and chest with diaphragm. Even 1 ml of air is there inside the abdomen, you will identify it. It is always done erect abdomen only, not supine abdomen, erect abdomen. Okay. And the gold standard is CECT. Gold standard is CECT. And X-ray left lateral view, we can detect if 5 to 10 ml of air is there, only in left lateral position also we can detect. But X-ray erect abdomen and chest with diaphragm, both of them should be seen. Chest should be seen, diaphragm should be seen, and the abdomen should be seen. Okay. Yeah. See here, these are pneumoperitoneum, signs of pneumoperitoneum. Signs of pneumoperitoneum. Cupola small. See here, there is diaphragm here. Are you able to appreciate the diaphragm, the yellow lines?
Yes, sir.
Yes, sir.
Yeah. See both the diaphragms are clearly visible. There is air under the diaphragm. Here also there is air under the diaphragm. Okay. Completely it is filled with air under the diaphragm. It is dome sign or cupola sign. Dome or cupola. Cupola is nothing but the dome. Okay. So here also it is just like a football. Regular sign it is known as regular sign. RAGLER, regular sign. Regular. Okay. These are signs that there is hollow viscous perforation. Okay. So, what is the treatment for a DU perforation? Duodenal ulcer perforated. Okay. How will the patient present?
Hippocratic face.
Yeah, Hippocratic
Guarding
face,
will be
abdomen
there,
will be
rigidity
guarding,
will be
there will be
there.
rigidity, everything. Yeah, very
Liver
good.
dullness.
Okay. Liver dullness is obliterated. Good. So then you did the X-ray erect abdomen, you found diaphragm, gas under diaphragm is there. So what you will do? You will do it for it in emergency laparotomy. Give fluids, make the vital stable, take him to the OT. So inside the OT, you did an abdomen, you opened the abdomen, you have seen the duodenum. So if less than 1 centimeter is there, very small thing is there, less than 1 centimeter, direct closure. Just close it. Okay, direct close it with some suture. If it is more than 1 centimeter, again put some omental patch. This has a name for it. It is known as Graham's patch. Graham's patch closure. Okay, just put the just take some momentum and put over it and suture over it. Okay, and if it is a big fistula, like it is a big opening, big perforation, more than 3 centimeters perforation. Okay, then you have to do a gastrojejunostomy. You have to I'll tell it. Listen carefully. If less than 1 centimeter, closure. More than 1 centimeter, omental patch. If more than 3 centimeters, this much has opened up. This much has opened up. Okay, this much perforation is there. Okay, so I am telling you, leave it like that. Don't do anything here. Just do a gastrojejunostomy. Leave it. Don't do anything here. Just close it off and do a gastrojejunostomy. Why? In the same way, when how we treated gastric ulcer, if a gastric ulcer is there, I told you to resect it off. Remember, I told you to do a partial gastrectomy and resect the ulcer off. But here I am not telling to resect the duodenum off. Why is it so? Is duodenum more important than stomach? I'm just telling, leave that like that. Just don't do anything to that. Do a gastrojejunostomy to bypass the food. Why is it so?
Gallbladder secretions come into the liver or duodenum.
Sorry?
Gallbladder secretions also fall into
Very good.
duodenum.
Yeah. It is not just, you cannot remove the duodenum like that. Because what happens? There is, at the D2, at the level of D2, we have the, suppose this is the liver, this is the gallbladder, we have the cystic duct, we have the common bile duct. Everything will open here only. In the same way, pancreas is there. Pancreatic duct will open here only. Okay, so it is like a multiple junctions are there. You just can't remove it because everything will be hanging then. Pancreatic juice where it will go, hepatic juice where it will go. So duodenum, you have to respect it. You cannot remove the duodenum like that. Okay, so we will leave it like that. We will bypass the food channel. We will do a gastrojejunostomy so that food will go from the gastric from the stomach to the jejunum, and these juices will come from the duodenum. It will go into the jejunum. Okay, is it clear?
Which ducts did you say opens up on D2?
Sorry,
Which ducts did you mention that they open in D2?
pancreatic duct. One is pancreatic duct, which will bring the pancreatic juices. One is from the liver, cystic duct. One is from the gallbladder, bile duct. These both join to form the common hepatic duct, and everything opens at the D2 only. Okay.
Okay, got it.
Yeah.